Hi, I'm Alex. I'm a PhD student in Computational Precision Health, and my work focuses on AI for cardiology. In the paper I'm presenting here today, we are focusing particularly on the diagnosis of acute coronary syndrome, often known as heart attacks, from the electrocardiogram. So the general diagnosis of acute coronary syndrome from the electrocardiogram focuses on a small set of features that have been discovered over 100 years ago, and where there's quite substantial evidence that they are not very sensitive or specific. And so, given that, and given the importance of diagnosing and identifying patients with heart attack early, a natural question is can AI help? And can we now use these unstructured ECG waveform signals to identify patients at high risk? And the one answer is yes, but to make this possible, we require data, and we require also good outcome labels. So, because since the cardiologist annotations or the features that cardiologists use to just diagnose or infer heart attacks of the ECG are not very sensitive, just training a model to replicate these is not going to help us to become substantially better at this time. So in this work, what we do is that we have compiled a new data set that links ECG waveforms to outcomes of cardiac catheterizations, where there was a different procedure that gives a detailed view of coronary blood flow, and therefore allows to identify quite certainly whether there's a blockage. We then use this data set to evaluate different predominant machine learning approaches and structured annotations from cardiologists of the ECGs to compare their performance in detecting actual heart attacks and these actual labels. And our results are quite promising in that they show that the best machine learning model is able to identify a risk group that has the same yield, same testing yield as the best human feature, which is the elevation, but identifies a larger patient population, and also and of this patient population, a large portion of them don't have any currently known features you would screen for in the cardiogram. So that is one part. But then the most exciting part about this project is actually that we make this data set, the models, the code, and everything we use publicly available. And in addition, release a holdout set that is unlabeled and link it to a Hugging Face leaderboard to compare performance, and to now enable everyone to build basically upon the initial baseline that we have set and hopefully surpass it soon, and help us in this way as a community to improve the diagnosis of heart attacks.